Perfect. So our next speaker today, I'm very pleased to present to you is Dr. Roger Stanworth, who is going to be talking today on hypogonadotrophic hypogonadism. Roger is a consultant endocrinologist in Derby and has been for 15 years, and his subspecialty interests include pituitary disorders and andrological endocrinology and gynae endocrinology. And we are very fortunate that he's been working alongside Professor Jay Prakashan in the Derby Gynae Endocrine Clinic for the majority of his consultant career. And so we're very pleased that we've roped him in today to give a wonderful talk. So Roger, if you're there, if you're able to share your slides.
Thank you, Emily. Absolutely wonderful presentation that you've started us with today, and a very kind introduction as well. It's always a great pleasure to work with Jay and the team, and as has been alluded to, I am an endocrinologist. Put it on the table to start with, and I guess the audience today, probably not too much too many endocrinologists present, so obviously it's an MDT audience as well. My specialty areas, as alluded to, are within pituitary as well as the gynae endocrine field, so hopefully well placed to cover this topic, but there is a risk that I'll glance past bits that need focusing more on for this audience, or focus on things that you're less interested in. So certainly do put stuff in the chat box for discussion at the end, and we'll come back to anything that you need to. And then the other thing to say is, as an endocrinologist, I'm not directly involved in the actual giving of fertility treatments, and a lot of the talk today will be focused more on the management of these conditions as patients lead towards fertility. Can I just check that the slides are sharing okay?
It's fine, Roger. If you don't mind, perfect.
Yeah, sorry, there we are. Sorry, I didn't go there. Right. Okay, so get it to move on. So yes, in terms of the title of the talk, WHO Type 1 Ovulatory Infertility and Treatments and Diagnosis thereof. So I'll just be recapping again how that fits into the overall picture that we've already heard about in terms of subfertility. I'll then be sort of subcategorizing WHO Type 1 ovulatory infertility. And then the main sort of body of the talk is around pituitary conditions, how they present, what are the initial steps you take if you're suspecting a patient may have a pituitary problem in the fertility context, what tests do you need to do, where the diagnosis may likely head, and I'll then sort of branch into how the prolactin side of things comes into the picture. Prolactin obviously being a pituitary hormone, but also a subset of conditions that cause fertility problems in this context. And then I will move on to congenital hypogonadotrophic hypogonadism and hypothalamic amenorrhea for a few slides at the end. I always find when people hear you're an endocrinologist, they always sort of feel like hormone or endocrine things are complicated, and they're really not. They're kind of linear things. When we talk about hormones and the way they affect each other, these are linear effects. You'll have a stimulatory or inhibitory effect. There's often a negative feedback loop. So we try and I don't know if we try and make it complicated, but the end result seems to be that we give that impression. But hopefully, today we'll dispel some of that. The slide here shows a visual representation of the hypothalamus at the top, the pituitary, and then the ovary at the bottom. And if we're talking about as I say, a negative feedback loop there, we've got hormones originating at the top in the hypothalamus, in this case GnRH. It's going down the pituitary stalk in that sort of microcirculation, if you like, to the pituitary as a stimulatory effect to produce LH and FSH, and then LH and FSH in the systemic circulation to the ovary then producing hormones, including estradiol, and then negative feedback to the pituitary and hypothalamus. So that's the basics of the situation. And so when we talk about anovulation, the WHO categorization, we've got WHO type 1, which I'll be covering today. WHO type 3 is ovarian failure, which again we've got a talk on later, and WHO type 2, the PCOS, in a way it's not as simple as a hormone deficit or a resist or a part of the body that's shut down, and we have got another talk on that today, but that's certainly a more complex physiology. But the WHO type 1 is the failure of hormone production at the hypothalamic pituitary level, and then as an ovulation that's a case of anovulation that's occurring due to that. And that's not the commonest cause, as we heard a moment ago. PCOS is in the overall causes of anovulation, and that's obviously a very common condition compared to pituitary disorders. But just to emphasize here, if we've got a pituitary disease or a pituitary tumor, that can be certainly a cause of hypothalamo pituitary failure. As I've alluded to already, and I'll be talking about later in the talk, the congenital hypogonadotrophic hypogonadism and hypothalamic causes are also here, but prolactin does sit within this, and I'll talk more about how prolactin links into pituitary disease as a whole. So just in passing, the scan on the right is a relatively normal pituitary scan. This is a view where we've taken a cut through the front of someone's head, if you like, and the pituitary gland is in the center between the two black dots. Let's go between underneath the sort of center of the brain, and above the pituitary gland there's the optic nerves. There's also a little stalk that links the pituitary gland to the hypothalamus and central control centers. And when we're talking about pituitary disease and anovulation, it can be, hypopituitarism, which means pituitary gland is not working. That process of hypothalamus communicating with pituitary, providing that stimulatory effect, has failed. That's one reason why anovulation might occur. Hyperprolactinemia can be part of hypopituitarism, but in its own right, even when it's due to other causes, can reduce gonadotroph function, so reduce LH and FSH production, and therefore inhibit ovulation through that route. And as I've alluded to already there, the pituitary is at the center of, we've described it in terms of the hypogonadal pituitary ovarian axis earlier, but there's an equivalent hormone axis that controls the thyroid, controls the adrenal gland. So it's, this is a pea-sized part of the body, and it's actually controlling a wide range of processes through the body. And I think when you think about the way that pituitary problems can present, you can quite quickly see how the symptoms can be quite broad when you think about it that way. And then the other thing to mention here is that I've so far described a stimulatory effect of hypothalamic hormones on the pituitary gland, and that's the case for almost all the hormone systems in the pituitary. The one exception is prolactin. So if you get a failure of hypothalamic control, so if the stalk that links the hypothalamus and pituitary is disrupted and that local circulation can't deliver the hypothalamic hormones, then it's inhibitory control for prolactin, so that the prolactin will actually go up if that communication is dropped, whereas for all the other hormones you get low levels of estrogen, thyroid hormones, adrenal, if the pituitary is not working. So in terms of that phrase hypopituitarism, which we've been through there and explained the origin of that failure of hypothalamic pituitary function, traditionally it's not entirely, you wouldn't say entirely that hypopituitarism is therefore a pituitary tumor, but it's, if you have a hypopituitary patient, it's highly suggestive of a pituitary tumour. And patients with multiple lacking hormone systems working through the pituitary gland, i.e. hypopituitarism, we traditionally said 90% of those cases will either be pituitary tumours themselves or other suprasellar, other tumours in that area, or the treatments thereof, whether that be radiotherapy or pituitary surgery. So obviously that should come out in the patient history. They should know if they've had those treatments. If they're newly presenting with a hypopituitarism and they don't have any interventions in the past, and they haven't had radiotherapy for a some sort of lesion elsewhere in the face or brain, then it would suggest they may have a pituitary tumour. The other 10%, that's 90% of those, 10% is a collection of rarities and idiopathic cases. So things like sarcoid, other inflammatory disorders, or indeed Sheehan syndrome, so relating to postpartum hemorrhage and damage to the pituitary gland from that. So sort of very interesting cases, but that 10%, actually the majority of it, we wouldn't pick up a specific diagnosis. We would be left with an uncertain cause. And then the other thing to mention is that in this era of new cancer treatments, there's a range of medications. We sort of broadly refer to them, certainly from an endocrine perspective, as checkpoint inhibitors, and those medications can have a large range of autoimmune complications, and that includes pituitary swelling, pituitary dysfunction, and so that group is coming forward now. How much that shows up at this point in a fertility population, relatively young females, well, maybe not so much for now, but again, these treatments are becoming more common and we should all be aware of them. So as a result of all this, the typical hormone pattern, if you've got the mechanism here is a pituitary tumor that would disrupt that anatomy linking the hypothalamus and the pituitary, and therefore the loss of those hormones coming from the hypothalamus to the pituitary, and therefore, as I said, low everything apart from a raised prolactin. That's a typical pattern of somebody with a non-functioning pituitary tumor, where it's a pure lack of that stimulation rather than an extra production of a hormone from the pituitary. So what do you need to know about pituitary tumors themselves in order to kind of start embarking on thinking about investigating them, or indeed starting to raise with a patient that you're starting to investigate it, and not set too many hairs racing, because that is important not to cause too much concern along the way here. When we do diagnose pituitary tumors, these are almost completely benign and slow growing entities. They will generally present in females earlier than males. The archetypal way of presenting as a female is to lose your menstrual cycle and get medical assessments, or indeed fertility and get medical assessments due to that reason. The kind of archetypal way to present as a male is to have a visual field defect later in life, crash a car, and be found on a brain scan to have a large pituitary tumor, which has then grown so much that it's affected your vision. Tumors can be functional or non-functional. So prolactinoma is an example of a tumor that you'll all have heard of, that is making extra prolactin hormone. So that's directly coming from the tumor, but there are other ones as well. And whatever the pituitary tumor is, it can result in that hypopituitarism mechanism that I described there. So typically, if you imagine a pituitary tumor starting really tiny, little tiny needle-sized bleb in the middle of a pituitary gland, that's not going to affect that sort of communication between the hypothalamus and pituitary. It's going to have to get pretty big to start pushing stuff out of the way and disrupt that link between the pituitary and hypothalamus. So it's as the tumor gets larger, it can do that. And then as the tumor gets larger as well, the actual direct mechanical effect of the tumor that we concern ourselves mainly with is when it starts to grow upwards or superiorly outside of the pituitary fossa, and eventually it'll contact the optic nerves, and then eventually that can stretch those nerves, cause dysfunction, and the pattern of visual loss you get with that, if it's typical of a pituitary case, would be bitemporal hemianopia, which means loss of left lateral field in the left eye or loss of right lateral field in the right eye. If the tumour is functional, so if it's a prolactinoma, then your functional symptom might be milk production, but other functional tumours from the pituitary gland include for Cushing's and for acromegaly. So these are sort of syndromal type things that can potentially be just a odd appearance, or sort of an appearance that you'd see almost in passing, although there are specific signs and assessments you can make, again, possibly outside the scope of this talk. And then symptoms of a pituitary tumour. This slide is troublesome because it's extremely incomplete and really just a grounds for a discussion. I think it's really difficult to write down the potential symptoms of a pituitary problem, because you could write down almost, if not the majority of possible symptoms in the world, a good subset of them. And some of them near the top of the list are symptoms that are incredibly common due to other reasons, or even for no particularly apparent medical reasons, such as tiredness. So really, it's a tricky one. On the one hand, I think if you're faced with a patient who you're thinking has, from the sort of fertility initial testing point of view, the assessments that Emily mentioned, you've picked up that there's a low estrogen, a low LH and FSH, you're sort of thinking in this ballpark, then to be honest, a starting question of, well, how are you generally day to day is reasonable, because if they say they're absolutely brilliant and fantastically well, then that sort of helps you out a lot. Obviously, people saying they have tiredness in response to that question is quite common, and then you do have to go through and try and elaborate further about other factors: sex drive, coldness, weight change. There's a variety of possible symptoms that are there, and that's just to do with the reduced pituitary function. There may also be particular symptoms, so acromegaly symptoms, changes in shoe size, changes in ring size, unusual appearance. Cushing's symptoms are a whole talk in their own right, probably. In terms of the structural effect of the tumour, it's actually relatively rare that people present with vision loss unless it's a very late presenting thing. Even if they do have some peripheral vision loss, they would be unlikely to notice that in the early stages. And headaches themselves, unless the patient has acromegaly, on average, pituitary tumours don't cause headaches. So obviously milk production can be a helpful symptom, but again, the rest of this is really quite difficult to pin down to individual symptoms. But what we can say is that if you, at the end of the day, I think it's reasonable in hypogonadotrophic, hypogonadal context, so where you've got a low estrogen, you've got low LH and FSH, you're going to have a low threshold. Really, for most patients, you're probably going to end up doing a pituitary hormone set. And this is a pituitary hormone set right here. So it's worth noting these down, because if you include them all, then you're kind of job done the first time. Otherwise, you end up repeating bloods a couple of times to get all the key things done. The key one that's tricky is the cortisol. Most of the others, there's a sort of normal range or reference range that kind of tells you whether you got a normal result or not. Cortisol is a bit tricky because you quite often end up with a result that's kind of indeterminate. Or if patients are on inhalers, so if they've got asthma and they've got a steroid inhaler, which is extremely common, then they can have a very low cortisol if they've taken that inhaler that morning, and then suddenly you're getting an urgent call from the lab a few hours later, and you're sort of making work for yourself and concern for the patient. So I think making sure you get a cortisol done that's omitting inhalers, omitting other steroid medications for a day or two, and getting as a 9 a.m. test gives you the best chance of a nice clean result and a sort of reassuring rather than unnecessary escalating kind of pathway. If you are thinking that patients got acromegaly or Cushing's, well, you can check an IGF-1 for acromegaly. That's a reliable screening test for most patients. That's probably job done. But if you're thinking Cushing's, you really need to just talk to your endocrinology team, refer to that team, because they'll need to take that forward. And pituitary imaging, well, it's all about MRI scanning, only if there's a clear contraindication to MRI would CT be considered, and functional imaging is a rarity as well. So, you know, the question to answer again is whether an MRI scan of the pituitary gland should be done. Again, relatively low threshold, unless you have, if you've got a patient with low LH and FSH, low estradiol, unless you are very clear what the cause is and it is not a structural problem in the pituitary gland. So, for instance, if you're very clear that it's a low body weight situation and there's no other features of pituitary problems, then fair enough. But a lot of these patients will benefit from pituitary imaging to rule out any problems. And to emphasize, now it's easy to get carried away particularly if you find a big tumor on a scan, or if that's the context of things coming to light. You know, the tumor sort of grabs attention, and sometimes the hormones seem less exciting in terms of treatments. But actually, you know, as we'll see in a moment, kind of intervention for a pituitary tumor only sort of helps in certain ways, one really specific way actually, and the rest of treatment for patients with hypopituitarism, even with a big old pituitary tumor, is pituitary hormone replacement. And you know, in terms of life-saving care for these people, it's all about the hydrocortisone. So you know, you want to make sure that we, where needs be, make appropriate diagnosis of hypoadrenalism and get patients on hydrocortisone safely. The needles aren't generally that big, but it's a historic slide. With that, so hydrocortisone patient education, it's not just a case of giving hydrocortisone tablets. We also do offer injections that patients can use themselves, written information for them to present acutely with to hospitals to raise awareness of their condition with healthcare professionals, and then education sessions where they and their families learn about how to amend their treatment during various things that happen in life. Certainly, you know, and then again, thyroid medication is a lot more straightforward, usually a daily dose of something that keeps stable, and very similar to a regime that you see in other thyroid patients. You know, if patients heading towards pregnancy, though, you know, they need these to be managed. And if patients are on hydrocortisone, levothyroxine, they do need endocrine monitoring through pregnancy, referral into the antenatal endocrine service as well. And then in terms of the hypogonadal side, well, our usual treatment for hypogonadal men is testosterone, not appropriate if those men are planning fertility and they require gonadotrophin treatments. And similarly with females, you're looking at some form of combined HRT up until age 50 to 52. That can be an important thing, you know, even if it's a fertility context. If ladies have been hypogonadotrophic for hypogonadal for a long time, getting HRT on board in terms of optimizing the uterus for pregnancy can be helpful, and obviously that can lend itself to future fertility treatment attempts. I mentioned pituitary surgery and the limitations thereof. So just to mention along the way, prolactinomas, they're managed medically. We'll come to that in a minute. Other functioning tumours, it is pituitary surgery, so they do have indications for that. But if we're talking about pituitary tumours beyond that, surgical intervention is mainly to preserve vision. So if the tumour is affecting vision, or it's at risk of affecting vision, and you know, bear in mind that pregnancy does cause an increase in pituitary size and pituitary tumour size, so you do need to think about, you know, planning for that. But ultimately, surgical intervention only solves the vision thing. It's on average not the case that surgery improves pituitary function. So on average, you wouldn't be putting someone through a pituitary operation on the basis that you'll then improve their pituitary function and therefore their fertility. Although, you know, you can get lucky, it can occasionally happen. Certainly, if someone's got intact pituitary function and then you know about a pituitary tumour, if they want fertility, it's better. Well, it's certainly a consideration that pituitary surgery would be a risk to what is intact fertility if you're going to go down that track. So, considerations about surgery and how it links into fertility plans is something we think about in pituitary services. Other tips in this area, just it's just two really quick points, really. So hormone dysfunction in pituitary tumors tends to occur in a predictable order. So basically, the sex hormone, the hypothalamic pituitary ovarian axis, tends to be pretty much the first one that goes. So that does mean it can be the only hormone sign, but there is still a pituitary tumor as the cause. So again, that's why a lot of these patients, we will end up with a pituitary scan just to rule out that there's a problem, even when there's not other hormone findings. But flipping that the other way around, if patients do have, or if females do have regular periods, hypopituitary is unlikely. That as a single question can sort of help make pituitary dysfunction unlikely. It doesn't rule out they got a pituitary tumor, but it does make pituitary dysfunction less likely. And then really briefly, obviously in the interest of time, just as once you start to get hormone results back, taking the we'll stick with the estrogen as the example. If you start into when I'm describing about how these hormones work together, we often describe it as the hypothalamus first, then the pituitary, then the ovary. It's really important. It saves you a lot of confusion, I guess, when you're interpreting the test, to start it the other way around. So start with the end hormone, the estradiol. Is it low or is it not low? And then work back up. If it's low, is the pituitary doing the right thing to try and compensate for that? So in the case of the pituitary, if estradiol is low, the normal pituitary response should be a high LH. Is the LH high? Well, no, it's not. In this case, LH is 5, is well within the normal reference range. Now, so a normal pituitary response to a low estradiol would be a high LH. Therefore, that's a failed response. The reason, if you imagine trying to interpret it the other way around, if you start by saying, oh, well, the LH is normal. Okay, so the pituitary is normal. Oh, and then you've confused yourself, and it's just difficult to retrace steps on that. So start with the end hormone, work back up, makes it simple every time. Okay, so moving on to hyperprolactinemia. So prolactinoma, as an example of something that causes high prolactin, I will come to other causes in a moment, can either cause interruption of or it can cause anovulation by the usual process we've just heard about with hypopituitarism and that hypothalamic pituitary lack of communication, or the prolactin itself can suppress gonadotroph function, so it can reduce LH and FSH production. So those are two separate mechanisms. They can be occurring both together in the same patient if you've got a large tumor that is a prolactin producing tumor, but that's the mechanism. And hence to whiz past this one, but that's the sort of physiological, or if you look at it from a sort of the way our evolution has happened, I guess the principle is, from an energy energy point of view, breastfeeding inhibits fertility for kind of good reasons. If you're still breastfeeding, it's not the time to be channeling energy into producing your next offspring. So that's the kind of easy way of remembering that. And in terms of causes of hyperprolactinemia, it's always easy to start with the prolactinoma, but that's a very small subset actually of causes of high prolactin. So prolactin is a stress hormone. So if someone comes into I don't know, A&E resus with an acute illness, it'll probably be high. If someone doesn't like a blood test, it'll probably be high. It used to be used as a differentiation between pseudo seizure and seizure, because again, it's a stress hormone. If you're having a genuine seizure, you would expect hyperprolactinemia. We've moved on from that, but it sort of makes the case for prolactin being something that can go up and down day by day. And so certainly you would always want more than one test before you start going down the track of there being a genuine prolactin problem. There are other medical issues, particularly renal failure, hypothyroidism, and also polycystic ovarian syndrome that can be associated with hyperprolactinemia. There are lots of medications that can affect, give you a high prolactin via, mainly via dopamine effects, because dopamine is that inhibitory control for prolactin from the hypothalamus. So messing about with that messes about with prolactin. The really powerful ones are Antipsychotic medications, they're the commonest, and then antiemetics, metoclopramide and domperidone. There are then a collection of other medications that have a less powerful effect, but those are the powerful ones. And then, yes, it can be part of stalk effect, so that's a link to hypopituitarism, and then prolactinoma itself. If your normal prolactin level depend on your local assay. Roughly speaking, though, your assay might say that a normal prolactin is up to 500. Between 500 and 1,000, actually significant pituitary pathology is less likely. Doesn't mean that it can't be affecting ovulation, so we'll come to that in a minute, but less than 1,000 is less likely that there's significant pituitary pathology. Greater than 5,000, some people even say 3,000 to 4,000 will almost always be a prolactinoma. And then you've got the bit in between where, yes, it could be a number of things, but could indeed be a good going pituitary problem. Plan does depend on the cause, as you can imagine. So the plan for someone on medications directly causing this problem may be different from someone who's got a prolactinoma, as you can imagine. But in terms of overall approach, there are actually a couple of things missing off this slide. But nevertheless, as I've already mentioned, you need to repeat a test. Often will resolve on repeat testing. If you've got an intermittently raised level, it's not clinically significant and doesn't require specific attention. Because kidney function and thyroid function can affect prolactin, those obviously need to be assessed. If you can address the cause by stopping a medication, well, that's great, but that's going to be a lot easier for an antiemetic where there might be other options that don't affect prolactin compared to an antipsychotic medication, which I'm sure we would all be reluctant to unilaterally change. Of course, you can liaise with psychiatry, but these things are often difficult to do, albeit that there are some medications within the antipsychotic group that cause less problems. You then check the overall pituitary bloods, as we saw from the other case. Do also then consider a pituitary scan if there are enough features. Consider PCOS as a potential contributor. And there are various ways of looking. If PCOS is a part of the picture, we're not expecting estrogen deficiency, so then we can sort of look at it that way around. If the prolactin's high and there's signs of estrogen deficiency, well, that looks like more pituitary. If there's not signs of estrogen deficiency and prolactin's high, well, maybe PCOS is the primary cause. And then going back to that day 21 progesterone that Emily mentioned, which I suppose we should call a day -7 progesterone, but doesn't have an easier ring to it. If that's suggestive of ovulation, then, well, the prolactin might be there, but it's not affecting fertility. It's not inhibiting ovulation. So we'd encourage people to just move forward with the fertility side of things, and maybe the prolactin's unlikely to be significant and is also not affecting fertility. Treatment of hyperprolactinemia, basically, in terms of treatment, if you've got a prolactinoma, well, you probably do need prolactin-lowering medication because it will shrink the tumor as well as reducing prolactin. If you've got oligomenorrhea, that tends to be a marker of estrogen deficiency in this context, so that's a good reason to treat prolactin. And most relevant for today, if you've got subfertility, so if your progesterone is low with a high prolactin, or again, if you've got oligomenorrhea, that suggests subfertility in this context, you may well treat hyperprolactinemia. Treatment means medical treatment in most cases, and cabergoline is our most frequently used drug. It's a half to one tablet once or twice a week. We would always do pituitary imaging first because you shrink the tumor by giving the treatment, and therefore if you start the treatment first, you may not get a good representation of the natural history of the disease to sort of take forward into further management. People can get side effects, so that's typically sickness, headaches, and dizziness, but they usually settle after the first few doses, so then that's fine as long as you counsel patients. It's very rare that I have patients that can't take it. There is a risk declared about heart valve health, but to be honest, I won't go into that too much today. We've kind of dispelled that. We still mention it to patients. We do a baseline echo, but it's not a major concern. The one concern that does remain is risk behaviours. So if you're on these medications, changes to like compulsive behavior, so compulsive shopping, compulsive gambling, it's best to warn patients, but actually, at least as importantly, ideally a relative, so that they can look out for this on their behalf. So in brief summary of this main part of the talk, low estradiol, failed pituitary response, think pituitary disease. Symptoms can be really non-specific. Anovulation in this context can be directly from hypopituitarism or from the prolactin or both. The pituitary hormone levels and the MRI pituitary are the mainstays of investigation, and for the majority of cases you'll just get on and do those. Keeping a list of those pituitary hormones for the right moment when you need to do them is useful. Pituitary tumours are the commonest cause of hypopituitarism, but they are usually conservatively managed, and it's usually a lot about hormone replacement therapies of various types, both what you guys talk about, HRT, and broader hormone replacements from the endocrine world. And then hyperprolactinemia has got many causes, but subfertility relating to it is an indication for treatment. So that judgment of whether hyperprolactinemia is relating to subfertility is key. But again, repeat testing is crucial before going too far, because hyperprolactin can just be there for no particular reason on one given day and then self-resolve. Just 2 slides on each of these more, I guess, rare scenarios, or just to mention the pertinent points. So in terms of congenital hypogonadotrophic hypogonadism, well, when we say that, I guess we're mainly talking about Kalman's syndrome, which is isolated hypogonadotrophic hypogonadism, so failed hypothalamic pituitary function of that particular isolated type with no other features, but with anosmia. So this is to do with an embryological link to how the nerves that governs smell are linked into this, or without the smell, without the anosmia, and again the isolated thing. So we're mainly talking about that, but just to be aware, this is a really complex area genetically, so there's a massive number of different genes that can just link into those pure cases, but there's also genetic causes of hypopituitarism with multiple hormone deficiencies. There's also a variety of genetic problems that can have either hypopituitarism or isolated hypogonadotrophic hypogonadism as part of a broader syndrome systemic picture. So I do think again, pituitary bloods, consideration of pituitary MRI in some of these patients, they will generally be presenting having had having failed to go through puberty and or failed to ever have periods and or in the subfertility context, but they can actually be presenting many years later with that having happened to them. Excluding a structural pituitary problem and broader pituitary dysfunction is important. And once you've done that, you can do it. We can all do panel testing for various genetic conditions these days without referring to genetics. I think in this setting, a low threshold for involving an actual geneticist is important, because the panel test is incomplete, and it is not as straightforward as a lot of genetic testing areas, I would say. And then finally, hypothalamic amenorrhea. So again, Emily mentioned this for us earlier. We're talking about really, largely speaking, low body mass index linking into hypothalamic dysfunction, so lack of GnRH, LH, FSH. It's via a low leptin level, so that's the link into low body weight. Low leptin is a hormone that's produced by body fat, and there are studies that have given leptin to patients with this condition and shown that can resume normal menses and normal reproductive function, although ultimately that's not really a clinically useful treatment at the moment. And the bottom line is that lifestyle modification for this group is the key. Again, assessing pituitary function, ruling out a broader pituitary problem is part of the process. But yes, we're going to be looking at dietary modification, advising weight gain. Now, for the majority of patients, that is a conversation and will be effective. But of course, as Emily also alluded to, within this group, there is a subset with eating disorders. And if that is a known diagnosis, then you may well need to liaise with the psychiatry team that are looking after that condition with them, or the other specialty teams that are involved. Alternatively, if it's a new diagnosis, again, that could be a referral, and referral to appropriate services for those patients can be quite challenging. So, in terms of fertility treatment per se, as I said, I'm an endocrinologist rather than a fertility specialist. At the end of the day, if you haven't got, the underlying problem with this set of disorders ends up being, unless you can improve matters through things that we've discussed earlier in the talk, there is a lack of LH and FSH that's causing an anovulatory problem. So the solution to that is going to be gonadotrophin-based fertility treatment. How that ties into modalities of overall fertility treatments, I'll leave others to really describe if needs be. So hopefully we have covered most of what I've discussed there. I'm aware that cumulatively we're sort of a little bit behind, so I'll just glance past that and thank you for your attention and open for questions.
Thank you, Roger, for a very comprehensive overview of this group, type 1 ovulation problems. I think we are running short of time, and we would like to start the next session at 11 o'clock. But can I just ask one question? I know probably what you're going to say. Like when we are doing a fertility clinic, although they are ovulating and they're having regular cycles, majority of our referrals, the GPs do the prolactin levels, and it comes back as 700, 800. And then we are in a bit of dilemma and we keep repeating it, maybe a couple of times and things. And what's your view on that?
I think certainly one thing is to say, I mean, look, if we can show that, I think, as you quite rightly say, repeating the test, making sure it's a persistent abnormality, step one. Step two, if you've got regular periods, that day 21 progesterone is absolutely key, I think. And we can promote that, to anyone that's assessing patients in a fertility context. And if we can show that the day 21 progesterone is suggestive of ovulation, then really the prolactin can sit in that tells us two things. The prolactin isn't causing a fertility problem, and it's also extremely unlikely that you've got a significant structural problem in the pituitary gland and yet you're able to ovulate and with this high prolactin. So it's likely that you're not going to pick up much diagnostically there. So it's definitely fine then to progress on with what the patient really needs, which is whatever other fertility care they need. And fine, they could see an endocrinologist at some point. We could pick it up later, and certainly they should be advised if in the future they were to then stop having regular periods, that would be a sign to recheck prolactin, see if it's gone up further, see if there is more to this. But to be honest, as soon as you get to there being a regular period and there being a day 21 progesterone that's looking good, with that mild hyperprolactinemia group, I'd just move on.
Would you agree for an MRI, or would you do MRI at this stage?
With those ones, I would say no, but I think on the ones where it's not as clear as that, so perhaps they've not got completely regular periods, or the day 21 progesterone is suggestive of a problem, then that switches it back the other way, and then those are the ones that do need a scan. You could do obviously the pituitary hormone set as well. Those are the ones that do need the workup, and then can need some joint care between endocrine and fertility team.
Okay, well, one quick question from Rachel. Rachel, do you want to ask?
Oh yeah, thank you. I was just going to ask about checking macro prolactin, and if you'd recommend
turn your camera on, Rachel,
stage.
and if you can.
Yeah, so thank you. I mean, so look, that's a really good point. I didn't mention macroprolactin. So macroprolactin is in some patients, but in a proportion of patients, the prolactin molecules stick together, and it causes a falsely high level, really. And so if your prolactin is only high because of a macroprolactinoma, of a macroprolactin presence, then it will carry on being high without there being any disturbance in your true prolactin level. So my answer is, ideally, that any patient with any rise of prolactin should have a macroprolactin included. And our lab actually added it onto all our results, which is maybe why I've got lazy about telling people about it. I think in other units, they will only add it on if it's severely high, or if it's, like, for instance, I think it's commonly the case, some units they'll only do it if it's prolactin's above 700 or 800. Well, that only makes sense if you're not at all going to assess or open your mind to the possibility that those less severe prolactins need investigation. Because if we're saying we're going to investigate with MRI and pituitary hormone set and everything else, well, we need to rule out the macroprolactin first, because otherwise, we're all the more so in that mild group. So I would say any raised prolactin, get a macroprolactin just to save yourself a lot of work. If that's raised, then you can really shut that down and just say, well, look, that really isn't something we need to do. What you don't need to do is repeatedly check macroprolactin. If you've excluded it once for one patient, that's job done.
Thank you very much,
Thank you.
Roger. I think we probably